हेलो। 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 हाँ, मेरी आ रही है इसमें ऐप में। हेलो। अरे आप देख के बताओ। मैं तो स्टार्ट स्ट्रीमिंग कर दिया हूँ। फिर ये मैं अभी लाइन में हूँ, ऑनलाइन में और बात कर रहा हूँ आपसे। अब मैसेज में चेक कर रहा हूँ। हाँ, आ रही है, वॉइस क्लियर है। एक सेकेंड, एक सेकेंड। अभी आ रही है? अभी बेटर है? हाँ, अभी ठीक है? हेलो। बेटर है? और लाइव जा रहा है तो ठीक है, तो फिर मैं स्टार्ट करता हूँ। हम्म। हम्म। Okay, hello friends, I am Dr. Prashant Kumar, your orthopedic faculty at Global Academy of Medical Education, and today in this video we are going to discuss important orthopedic topics which may be asked in your upcoming FMG exams, right? So in this video we are going to touch some part of trauma, tumor, infection, regional orthopedics all together, okay? And we are going to discuss with your like upper limb first and then we'll go to lower limb, okay? So starting with, I have just draw a pictorial diagram of your upper limb, okay? And we'll discuss the first bone, which is your clavicle, okay? So important points regarding clavicle. So clavicle is the bone which is formation by intramembranous ossification, okay? So it's formed by intramembranous ossification, okay? So just, yeah, now it will be clear, I think. So it's formed by intramembranous ossification, okay? The most important or the most common part of the fracture is middle 1/3, okay? So it's middle 1/3, and that due to direction of pull of this sternocleidomastoid, so middle 1/3 fracture will look like this one, okay? And due to direction of pull, the upper part will go in basically the medial part will go upside and the lateral part will go downside. The downside will be go due to gravity pull of your proximal humerus, okay? And the upper part will go upward direction due to the pull of sternocleidomastoid muscle, okay? So discussing about this treatment, the treatment is really mostly conservative management, okay, by the help of clavicular brace or arm pouch or shoulder immobilizer. If it is well displaced, then we can apply the plate or tense nailing, okay? So basically management will be conservative only, okay? So after clavicle we'll discuss with the nearby joint, which is acromioclavicular joint, okay? So this one, so the acromioclavicular joint is due to formation of your clavicle and the acromion, okay? The joint is stabilized with due to this two ligaments, okay? One is the acromioclavicular ligament and second is the coracoclavicular ligament, okay, like this. So with the help of these two ligaments, the joint is stable. So in the case of this ligament damage, there is a acromioclavicular joint dislocation. So acromioclavicular joint dislocation, okay? And this dislocation is classified by Rockwood, okay? He classified in a 6 way, okay? So there is a 6 type, okay? 1 2 3 4 5 6. So in first there is only sprain in this acromioclavicular ligament, only sprain, okay? Second part where the acromioclavicular ligament gets torn, okay? So first part is only sprain, second part is torn, third is your acromioclavicular plus coracoclavicular ligament damage, fourth is due by the direction where it went, okay? So fourth is the posterior, fifth is the superior displacement, and the sixth is the inferior displacement, okay? So your clavicle and acromion is like this. So fourth is the posterior, superior, and then inferior, okay? So this is very important topic, is asked in your last AIMS exam also, like which of the ligament is damaged in the case of acromioclavicular joint dislocation, okay? So your answer will be the both your acromioclavicular ligament as well as coracoclavicular ligament, okay? Adjacent to that, let's discuss your proximal humerus, Okay, so let's discuss your proximal humerus. Okay, so the proximal humerus fracture is basically classified as a Neer classification. Okay, so it's classified by the Neer classification. So Neer classified with the help of giving a concept of part. So what is part? Whether the fracture gets displaced by the 1 centimeter or it's angulated by 45 degree. All right. So according to that, he classified as 1 part, 2 part, 3 part and 4 part fracture. All right, like in 4 part there is a 3 fracture line and there is a 4 different part. So the main thing is, as the part gets increased, the chance of avascular necrosis is also increased. Okay, so in 4 part fracture there is a high chance of avascular necrosis. Okay, so the important point where it can break, it can be break with the help of by at the level of anatomical neck, surgical neck, greater tubercle or lesser tubercle. Okay, apart from that, here like this is the greater tubercle, this is the lesser tubercle. So many muscles are attached to it, which is also known as your rotator cuff muscle. Okay, so that is your rotator cuff. Okay, here there is a 4 major muscle is supraspinatus, infraspinatus, teres minor and subscapularis. Okay, so as you can see, this upper third like supraspinatus, infraspinatus and teres minor is attached to your greater tubercle, whereas the subscapularis muscle is attached to your lesser tubercle. Overall, the 4 muscle gives stability of your shoulder joint and helps in the movement of your shoulder. Okay, so as we talk about this muscle, let's test this muscle individually. Okay, so to check the supraspinatus, there is a empty can test. Okay, to check infraspinatus, there is a external rotation lag test. Teres minor can be tested by horn blower test, and subscapularis is by belly press test or lift off test. Okay, so remember this important 4 tests. Okay, so in question may be asked like horn blower test is used for to test which muscle, so your answer will be teres minor. Okay, like that. So coming from this rotator cuff, let's go to your shoulder joint. Okay, this is very important joint. All right, your shoulder joint. Okay, so shoulder joint, some question can be asked like, it's a ball and socket type of joint. So it's a ball and socket type of joint. So it's high chance of dislocation because the glenoid is smaller and the humeral head is larger. Okay, so it can be dislocation. So dislocation can be of acute or a recurrent dislocation. Okay, if you talk about this acute, it is again divided into 3 parts, like the direction of dislocation. So it can be anterior, posterior or inferior. So by checking the deformity, okay, by checking the direction of your arm, we can check clinically whether it's anterior, posterior or inferior. In anterior, there will be external rotation plus abduction, whereas in posteriorly there will be internal rotation plus adduction. Okay, similarly in inferior dislocation there will be hyper abduction. Okay, which means your hand will be abducted like this. External rotation, there will be abduction and external rotation, and in posterior dislocation there will be adduction and internal rotation. Okay, so anterior dislocation is most common. So anterior dislocation is most common. Okay, whereas the posterior dislocation is common in the patient suffering from epilepsy or a electric shock. Why? So if a question asks regarding which shoulder dislocation, which type of shoulder dislocation is common in epilepsy or electric shock, it's a posterior dislocation. Okay, and in posterior dislocation on the X-ray, what you will get? You will get a peculiar sign known as your light bulb sign. Okay, so as your humeral head is rotated inward, so it looks like a light bulb. All right, and the peculiarity of this inferior dislocation is that is very difficult to reduce first, and second one is due to the important underlying structure like a subclavian artery, vessels and the brachial plexus, there is a high chance of injury of your plexus and important neurovascular structure. Okay, so the inferior dislocation is important regarding that. So let's go to your recurrent dislocation. So as you discuss this recurrent dislocation, there is a two important concept. One is your Bankart lesion and second is your Hill-Sachs lesion. So Bankart lesion, which means the defect in the antero-inferior glenohumeral ligament, anterior inferior glenoid. Okay, so yeah, so anterior inferior glenoid. So if you can see in this diagram, like this is the glenoid, this is the anterior inferior defect. It can be of labrum defect or it can be of bony defect. Similarly, it can be of soft tissue Bankart or a bony Bankart. Okay, so Bankart lesion is the anterior inferior defect of glenoid, whereas the Hill-Sachs lesion is the posterior superior defect of your humeral head. So as the dislocation happens, suppose this is the glenoid, this is the humeral head and dislocated in this manner. Okay, so your anterior inferior rim have defect, and similarly the posterior superior part of humeral head has defect. Okay, so depending upon the size of defect, the treatment protocol is set. Okay, so if it is a soft tissue defect, okay, like there is a labrum defect, then it will be repaired with the help of suture ankle. So we'll put the arthroscopic portal and with the help of suture ankle we'll tie this soft tissue labrum. Okay, similarly if there is a bony Bankart of more than 25% of defect, so this defect is not managed with the soft tissue coverage, we'll have to fill this kind of defect. So how will you fill? You can do an operation named as your lateral jet operation. Okay, so lateral jet procedure. Okay, so what you will do in lateral jet procedure, we cut a part of coracoid, along with this the muscle attached with it, like the sorted of biceps and the coracobrachialis, will remove the part of process and will attach on the defective part of your glenoid. Okay, so that is called as lateral jet procedure. Okay, and to counteract this Hill-Sachs lesion, so to counteract this Hill-Sachs lesion, what we'll do? We'll do a procedure named as remplissage. So what do you mean by remplissage? So remplissage, which means the filling of defect. So there is a humeral head defect. What we will do, we will put a suture anchor in defect and we will try to tie up this rotator cuff muscle and pull down to fill the defect. Okay, so that procedure is known as remplissage. Okay, so apart from this shoulder joint, let's move to your important nerves. So just along with this surgical neck, one important nerve is winding around, okay, name as your axillary nerve. Okay, so in case of surgical neck humerus fracture, there is a axillary nerve damage. Okay, and the axillary nerve supplies your deltoid muscle and teres minor muscle. So there will be atrophy of your deltoid muscle, and it also gives sensory supply along the anterior part of your deltoid, okay, which will generate an important sign known as regiment bat sign. Okay, like there is a sensory defect over this part where the badges are tied in a military person, so it's known as regiment bat sign. The question may be asked, regiment bat sign is seen in which nerve injury? Okay, and when we are talking about this nerve injury, then the nerve injury, its classification is important. So two classification is given, one is your Seddon and one it is your Sunderland. Okay, so most important is your Seddon classification, where it's classified as a neuropraxia. Second one is axontomosis, and third is neurotomosis. Okay, what do you mean by that? In neuropraxia, there is a damage of your myelin sheath only. So there is a myelin sheath damage. In neurotomosis, all the structure are damaged, like your endoneurium, perineurium. Only the epineurium is preserved. Okay, rest all structure are damaged. And in neurotomosis, even the epineurium gets damaged, the whole nerve gets torn. Okay, and this in the Sunderland classification, he divided the axontomosis into further three part. Okay, so this is a Sunderland classification. He classified as a 5 type. In Seddon, there is a 3 type. Okay, so this is the classification, and to do the investigation to check this nerve injury, what we'll do, we'll do your NCV test, nerve conduction velocity test. Okay, right. So apart from that, one important nerve which is lying in this spiral groove coming from posterior to anterior by piercing this lateral intermuscular septum, known as your famous radial nerve. Okay, so important point in the radial nerve, like when it gets injured, it will lead to wrist drop, okay, or finger drop. Okay, so these things you can get to see in the case of radial nerve injury. So most of the time it's praxia and it's recovered. Why it's so easily recovered? Because it is almost pure motor nerve. Okay, so in case of damage, like the question may be asked in that manner, that which of the nerve has highest tendency to get recovered? That is your radial nerve. Okay, similarly this radial, if it is injured and you will get this wrist drop or finger drop, then to protect these muscles, okay, will apply your cock-up splint. Okay, so important thing, like question may be asked like which kind of splint is used in the case of radial nerve injury. So your answer will be by use of Cock-up splint. Okay, and radial nerve is also gets injured in a special type of fracture like fracture shaft humerus, but a special variety known as Holstein-Lewis fracture. Okay, so if in question if they give indication or they give hint regarding Holstein-Lewis fracture, you should know the examiner is asking regarding your nerve injury. Okay, because in this type of fracture, like it's a lower 1/3 fracture of your humerus shaft where there is a pointed end and the nerve gets injured in that. Okay, so that is Holstein-Lewis fracture. Coming down step, in pediatric age group there is a fracture which is known as supracondylar fracture of humerus. Okay, so let's discuss supracondylar humerus fracture. Okay, so in supracondylar humerus fracture, here the 3-point relationship in the 90-degree angle will generate you an isosceles triangle. Okay, so the triangle is formation with the help of olecranon, medial epicondyle and lateral epicondyle. Okay, and it will create a typical isosceles triangle in the 90-degree flexion. Okay, and if it is extension, then all the 3 points in a single line. Okay, supracondylar fracture is seen in the pediatric age group, especially in the case of fall in outstretched hand. Okay, so in supracondylar fracture, the distal part moves proximally, okay, with medial tilt and internal rotation, and if it is malunited, then it's cause a deformity known as cubitus varus deformity. All right, so got my point. So the cubitus varus deformity is usually due to malunited of your supracondylar fracture. Okay, so in supracondylar fracture, the patient will present with intact vessels, which means your radial nerve, pulse and the ulnar pulse are palpable, or there is a damage of your blood supply, which is also known as your pulseless hand in a case of supracondylar fracture. So in question may be asked regarding what will be the management of your pulseless hand. So pulseless hand in supracondylar fracture is again divided into 2 parts, is your pink hand or pale hand. What do you mean by pink and pale hand? So pink hand, which means collaterals are still intact. Okay, so your SpO2 will, when you measure the SpO2, it will around 99 or 100%, whereas in the pale hand collaterals are also damaged. So the treatment will be, you first fix the bony fragment, which means CRIF, close reduction internal fixation, with the help of K wire, and check the vascular return. Okay, if the pulse are returned, then it's okay. If it is not, then refer to your CTVS guy, do the Doppler, check that where it gets injured and it can be repaired. Okay, similarly, apart from this supracondylar fracture, there is a lateral condyle fracture. Okay, so there is a lateral condyle fracture. So lateral condyle fracture will lead to cubitus valgus deformity. Okay, so here you saw this, here in supracondylar you saw this cubitus varus deformity, whereas in lateral condylar fracture you will get cubitus valgus deformity. Okay, important question which may be asked, like the tardy ulnar nerve palsy, like tardy ulnar nerve palsy is seen in your lateral condyle fracture, okay, where the it has the cubitus valgus deformity. So the ulnar nerve, which is going just behind this medial epicondyle, is getting stretched, and it leads to late neuropathy, which is also known as tardy ulnar neuropathy or tardy ulnar palsy. Okay. So apart from this lateral condyle, let's move to this medial condyle. Okay. So medial condyle is important as the ulnar nerve is passing just behind that. Okay, right. So any fracture happens in this medial epicondyle can lead to ulnar nerve injury. Okay, the similar question is asked in your last AIIMS exam. Okay, so if you talk about this your ulnar nerve injury, then the question may arise. Okay, let's go behind that. Your ulnar nerve injury. Okay, so you will get to see clawing of hand or paradoxical clawing. Okay, what do you mean by that? So in clawing, there is the extension of your metacarpophalangeal joint, whereas flexion of your the fourth and fifth finger, like flexion in your PIP and DIP joint. Okay, that's the clawing. Okay, whereas in paradoxical clawing is seen in high ulnar nerve palsy. Okay, so what happened in that? So if the ulnar nerve injured in the higher level, okay, so it's higher than the elbow, then the nerve supply which are getting the FDP, like flexor distorum profundus, okay, so FDP, the nerve supplies of FDP is also cut off. So FDP is responsible in flexion of your distal phalanx. Okay, so the severity of clawing will decrease. Okay, so that's why it's called as paradoxical clawing, and it's seen in high ulnar nerve palsy. Okay, so that's why it calls paradoxical clawing. Okay, so let's move to your elbow joint. Okay, I know it's a bit messy, but you will get, so till that, what you get this clavicle fracture, acromioclavicular joint, okay, then shoulder joint dislocation, your proximal humerus, your nerves, radial nerve. Okay, so in this manner we are going to study. Okay, so let's move to your elbow joint. So in elbow joint, what is important? So in elbow joint, the most important point is your terrible triad. Okay, so terrible triad, which means there is a posterior dislocation of elbow along with radial head fracture and coronoid fracture. Okay, so if there is a posterior elbow dislocation with radial head fracture and the coronoid fracture, this kind of dislocation is unstable. We'll need to all fix that. So question may be asked like, which in terrible triad, which structure are damaged, or what are the things which you are going to get. Okay, so this is terrible triad. So apart from that, this elbow part, two similar entity known as tennis elbow or golfer elbow. Okay, so tennis elbow means there is a injury of your which is also known as lateral epicondylitis, which means in the simpler term, okay, there is a injury in extensor carpi radialis brevis. Okay, right. So remember this tendon, the origination of the extensor carpi radialis brevis, okay, gets injured and can lead to tennis elbow or lateral epicondylitis, whereas in golfer elbow there is a epicondylitis in of your medial condyle. Okay, so medial epicondyle is epicondylitis of medial epicondyle is known as golfer elbow. Okay, so treatment will be conservative only, and this in tennis elbow, 2 tests are important which may be asked, named as your Cozen test or your Mills test. Okay, so these tests are to check your tennis elbow. Okay, coming down from the elbow joint, let's go to your forearm segment. Okay, so in forearm segment, yes, so forearm segment, the 3 important terminology is used, named as Monteggia fracture, Gallagher fracture, and Isses-Lopresti fracture. Okay, so what is that? Let's discuss. So the Monteggia fracture, which means this is a fracture of upper 1/3 of ulna plus PURJ dislocation, which means proximal radioulnar joint dislocation. Okay, so this is a fracture of upper third of ulna along with PURJ dislocation, is known as your Monteggia fracture. This Monteggia fracture, there is a Bardo classification or Bardo classification is there, where is classified as of 4 type by checking the direction of dislocation of your radial head. Okay, so in 1, the radial head is moved towards anterior, so it's anterior dislocation. Second is posterior dislocation. Third is lateral, and the fourth is the fracture of 1/3 of ulna along with fracture of your radial 1/3 of shaft. Okay, there is ulna with radius both bone fracture. Okay, and the direction can be of any direction. Okay, so remember this name is Bardo classification or Bardo classification. Okay, and it's a 4 type. Similarly, there is a second terminology known as your Gallagher fracture. So what is Gallagher fracture? So in Gallagher fracture, there is a lower 1/3 radius shaft fracture plus dislocation of DURJ, which means distal radioulnar joint. Okay, so distal radioulnar joint, as you can see in diagram, so distal radioulnar joint gets dislocated, and there is a proximal radioulnar joint is dislocated in Monteggia, whereas in Gallagher there is dislocation in distal radioulnar joint. Okay, so it's known as Gallagher fracture. Gallagher fracture is also known as fracture of necessity. Okay, which means you'll have to fix it. Okay, with the help of plating, we'll fix this radial head fracture, radius shaft fracture, and will reduce this DURJ. Similarly, the third point is your Isses-Lopresti fracture. So what do you mean by Isses-Lopresti fracture? Which means there is a disruption of your PURJ plus DURJ plus interosseous membrane. Okay, so there is a disruption of your DURJ. It goes along with your interosseous membrane, which attach the radial shaft and the ulnar shaft. Okay, and exited from your proximal radioulnar joint. Okay, so it's known as Isses-Lopresti type of fracture. All right, so after that let's go to your distal radius. Okay, so clear till now? Okay, so let's go to your distal radius fracture. Okay, so distal radius fracture. Okay, so in distal radius fracture, so in distal radius fracture, few terminology are used like Colles fracture, Smith fracture, Barton fracture, Schoffer's fracture. Okay, so what do you mean by Colles fracture? So in Colles fracture, there is a displacement of your distal part will be dorsally. So this is a dorsal displacement of your distal part, and the fracture is extra-articular. So fracture is extra-articular. So extra-articular fracture in the distal radius, okay, where the distal part is displaced dorsally, is known as your Colles fracture. Okay, whereas in Smith fracture, the displacement is volarly. All right, it's also an extra-articular fracture, but the displacement of the distal part will be a volarly. Okay, so the malunited Colles fracture, the deformity will be a dinner fork type of deformity, whereas in Smith the deformity is your garden spade type of deformity. Okay, so the deformity will look like this. Okay, so this is the dinner fork, and in the garden spade the deformity will look like this. Okay, so in question may be asked like garden spade of deformity is seen in which fracture? Option will be these four. You'll get to know that's a Smith fracture. Okay, if you talk about this Barton fracture, what do you mean by Barton? Barton, which means is a intra-articular fracture. So all this two type of fracture is an extra-articular, whereas Barton is intra-articular, and the fracture line exit, whether it's exiting the dorsally or volarly, is known as a dorsal Barton fracture or a volar Barton fracture. So always remember where the terminology use Barton is gives an idea of an intra-articular fracture. Coming to this Schoffer's fracture, Schoffer's fracture is basically indicative of your radial styloid fracture. Okay, this is also known as your Schoffer's fracture. Coming to the wrist only, one important topic comes into regional orthopedics. Okay, the tenosynovitis of your first extensor compartment, also known as your Decurane disease. Okay, so also known as Decurane disease. All right, so Decurane disease is the tenosynovitis of your first extensor compartment. Okay, so it's a tenosynovitis of your first extensor compartment, which involves the tendon, the abductor pollicis longus and extensor pollicis brevis. Okay, remember these two tendon. Okay, so the tenosynovitis will involve your abductor pollicis longus as well as extensor pollicis brevis. And how will you confirm your diagnosis? By doing test known as your Finkelstein test. Okay, so Finkelstein test. So what is Finkelstein test? It's a sudden ulnar deviation of your wrist in a fisted manner. So it's a fisted hand, so sudden ulnar deviation. So there will be pain in your first extensor compartment. So the idea will be that it can be a Decurane disease. All right, so coming to the your carpal bones. Okay, so let's discuss with your scaphoid. Okay, So peculiarity regarding scaphoid is your scaphoid is having a retrograde blood supply. Okay, it's retrograde blood supply. What do you mean by that? Like blood vessels, so the blood vessels are going from distally to proximal. Okay, so if there is a fracture, there is a high chance of avascular necrosis. So there is a high chance of avascular necrosis of the proximal part. Okay, right? So similarly, so how will you confirm your diagnosis? You can confirm with your stress X-ray, or MRI. Okay, so stress X-ray, which means forceful ulnar deviation, okay, and magnifying this scaphoid area to check whether it is fracture or not. In undisplaced fracture, there is a scaphoid cast will be used, and in the case of displaced fracture, there will be fixation with the help of Herbert screw. Okay, Herbert screw is also known as your headless screw. Okay, so it's known as headless screw. So both the fragments gets compressed with the help of screw. It looks like that. Okay, there is a shaft, there is a serration over there, and there is a serration over there. So this is the Herbert screw. And in the case of scaphoid cast, so in question may be asked, what will be the attitude of the hand? So it will be a glass holding position. Okay, so scaphoid cast, there is a glass holding position. Okay, coming from this scaphoid, let's go to our second carpal bone, which is known as your lunate. Okay, so what question may be asked regarding lunate? So the first question can be asked regarding the avascular necrosis of lunate is known as your Kinbock disease. Okay, whereas the avascular necrosis of your scaphoid is known as Preser disease. Okay, so Kinbock disease, which means the examiner is asking regarding lunate, and the Preser disease, the examiner is asking regarding scaphoid. Okay, similarly, if you can see, if you can draw this scaphoid, lunate, triquetral, trapezium. Okay, so this lunate bone is attached with intercarpal ligament from scaphoid, from capitate, from triquetral. Okay, so this is capitate. So two terminologies used. One is pedilunate dislocation, and the second is your lunate dislocation. So what do you mean by pedilunate and lunate dislocation? Pedilunate, which means the lunate is still attached in or remain in this lunate fossa, whereas the rest of the carpal bones, okay, are dislocated and goes dorsally. Okay, is known as pedilunate dislocation. And how it has happened? If the ligament which are attached with this lunate gets disrupted. Okay, this is known as pedilunate dislocation. And in the last stage of pedilunate dislocation, if lunate get dislocated, then it's known as lunate dislocation. Okay, where all structure remain in that place, only lunate is dislocated volarly. So it's dislocated volarly. Also known as, in X-ray, known as spilled teacup sign. Okay, so it looks like that. Suppose this is the X-ray, there is a capitate, hamate, this is a lateral view, and this scaffold, this lunate is dislocated volarly, so it's placed over that. Okay, known as spilled teacup sign. Okay, so get the idea of this perilunate and lunate dislocation. Let's go to our next part, which is known as scapholunate dissociation. What do you mean by that? Scapholunate dissociation, which means disruption of your scapholunate ligament. Okay, so scapholunate ligament gets damaged, so the space between your scaphoid and lunate is increased. Okay, and it's increased more than 3 mm. Okay, so if the space is increased, and this space, increased space, looks on X-ray and known as your Terry-Thomas sign. Okay, so it's known as Terry-Thomas sign. Alright, so question may be asked, Terry-Thomas sign is seen in which case, which condition? So this is scapholunate dissociation. Okay, so let's complete our this carpal bone. Let's go to your metacarpal region. Okay, so we'll discuss this metacarpal. Okay, so we are touching only the important points. Okay, if you want to know in depth regarding all that things, you should visit the extended video or the complete videos is just already in the app. Okay, so here we are discussing only the important points. Okay, I am trying to cover all this thing in a single page so that you will get a clear idea. Okay, so these points are important, this can be asked. Okay, this can be a one-liner. Okay, like that. So after completion of this carpal, let's go to our metacarpal. And if you talk about this metacarpal, so 3 important point. One is the fracture. Your fracture of your first metacarpal, or the base of first metacarpal, which is known as your Bennett fracture. Okay, this is known as your Bennett fracture. So in Bennett fracture is basically a intra-articular fracture. So it's a intra-articular fracture. Okay, and there is a displacement of base. Why it's displaced? Because of attachment of your abductor pollicis longus tendon. Okay, so in exam, this question may be asked regarding which tendon is responsible in displacement of your Bennett fracture. So that is abductor pollicis longus. Similarly, if the fracture is too much comminuted, so a comminuted base of first metacarpal fracture is known as Ronaldo fracture. Okay, so Ronaldo fracture is also an intra-articular fracture, but it's more comminuted. Okay, similarly, if you talk about this fifth metacarpal, so a terminology is known as your boxer fracture. So what do you mean by boxer fracture? So boxer fracture, which means there is a fracture in your fifth metacarpal head neck junction. Okay, so in the case of punching, okay, so there is a fracture of fifth metacarpal in the area of neck. All right, this is known as your boxer fracture. Okay, coming to this metacarpal, there is more one question which can be asked. Okay, regarding, okay, let's discuss over here regarding your trigger finger. Okay, so in trigger finger only one question can be asked, like which pulley is affected. So the answer will be A1 pulley. So what happens is trigger finger, like the flexor tendon which are passing through various kind of pulleys are attached over this finger. Okay, some are annular pulley, some are cruciate pulley. So if you talk about this trigger finger, the main pulley which is involved is known as A1 pulley. Okay, so tenosynovitis of this A1 pulley can lead to trigger finger. All right. Okay, so coming from that, let's go towards of your fingers. Okay, so in finger, okay, let's discuss over here. Okay, so in finger there can be a flexor tenosynovitis. So flexor tenosynovitis, okay, of your flexor tendon sheath. So an important sign is known as Canaveral sign. Okay, what do you mean by Canaveral sign? This is a composition of your four sign, which is swelling of finger, tenderness, flexion attitude of finger, and pain on passive extension. Okay, so these four part, which is swelling, tenderness, flexion attitude, and pain on passive extension, is compositively known as your Canaveral sign, and Canaveral sign is seen in your flexor tenosynovitis of your finger. Okay, similarly, if you talk about tumors, then one tumor can happen in this small tubular bone known as enchondroma. Okay, so what do you mean by enchondroma? So there is a cystic lesion on the metacarpal or phalanges. Okay, so it's an intramedullary cystic lesion of tubular bone. It can be of enchondroma. Enchondroma is usually benign and solitary, which means a single one. If it is of multiple, then the chance of malignancy is increased 2.5%. Okay, and in multiple enchondroma, two syndrome or two peculiar terminology is used. One is Ollier's disease, and second is your and the second is your Maffucci disease. So what are the difference? So Ollier and Maffucci. So Ollier which have multiple enchondroma, and in Maffucci multiple enchondroma plus cavernous hemangioma plus phlebite, which means deposition of calcium. Okay, so in question, if the examiner may ask regarding there is a multiple enchondroma with the chance of cavernous hemangioma or phlebite, your what can be a disease? So in option it may be asked Ollier, Maffucci, so your answer will be Maffucci. All right, so always remember that Maffucci have three things. Okay, multiple enchondroma, cavernous hemangioma, and phlebite. Similarly, one more tumor can be asked, which is known as your Brown tumor. Okay, so it's of Brown tumor, which means the increase in parathyroid hormones. Okay, so due to this secondary increase in parathyroid hormone, there is a peculiar feature of subperiosteal resorption of tubular bone. Okay, so there will be a subperiosteal resorption of your tubular bone is due to increase in PTH, which means hyperparathyroidism, also known as brown tumor. Okay. So okay, so fingers are there. So last two thing which may be asked regarding your jersey finger or mallet finger. What is jersey, what is mallet? So in jersey there is a avulsion of your flexor digitorum profundus, whereas in mallet finger there is a avulsion of extensor digitorum comminutus. Okay, so in flex FDP, so FDP is attached on the distal phalanx, and if it gets avulsed, so it's the inability to do flexion, and in mallet finger due to avulsion of extensor digitorum tendon is the inability to do extension, known as mallet finger and jersey finger. So in mallet finger, you all know, so you will use mallet finger splint, which means the main idea to do hyperextension of this finger and will keep in that position. All right. So this is the completion of your upper limb. Okay. So right. So what will you studied till now? We'll study the clavicle fracture, acromioclavicular dislocation, then we'll move to the shoulder dislocation, proximal humerus fracture, rotator cuff, your axillary nerve injury, radial nerve injury, ulnar nerve injury, your supracondylar fracture, okay, supracondylar fracture, then cubitus valgus deformity, cubitus varus deformity, okay. So similarly after that we learned like terrible triad fracture, okay, so terrible triad, okay, so this is the terrible triad, then the fracture of the forearm, okay, so fracture of forearm, which means the Bado classification for Monteggia and then Gallagher, okay, SS Lopresti, move towards your distal radius fracture, covered up your Duchenne disease, scaphoid fracture, lunate fracture, okay, so your avascular necrosis of your lunate, Kinbock, Prizer, tennis elbow, golfer, your metacarpal fractures, then we'll move towards tumor, enchondroma, brown tumor, and then last to jersey finger and mallet finger. So in a nutshell, we'll try to touch all the important topics which may be asked regarding your upper extremity. Okay, so we are going to end this video right now, okay, and then we'll move to next video. I will try to do it as soon towards lower extremity, okay, and we'll try to wind up all the important topic of lower extremities in the similar manner. Till then, keep steady, all the best.